Hello, my name is KBerens, and I will be presenting on the comparative study of conservative care options for medial and lateral epicondylitis. The conceptual framework for this study revolves around the condition of interest, which is medial and lateral epicondylitis. The occurrence ranges quite a bit. If you're looking just in the occupational setting, it can range anywhere from 0.8 to 29.3%, which is quite a variance. This is all dependent on the type of work that the individual does. A lot of times epicondylitis results from high force repetitive tasks. So you can see why there's quite a range based off of these examples of different types of occupation. I figure the employees at Dot Foods fall somewhere into this range based off of the repetitive nature of the job, the high force that's required for a lot of the tasks that they do on a daily basis, and the exposure of vibration based off of the machines they operate. Gaps in the knowledge. The biggest gap in the knowledge that I found in my literature review was the treatment options that are presented to patients on a regular basis. As you can see looking through this list, there's quite a wide variety of treatment options that are presented on a normal basis, and that's concerning because there isn't a lot of evidence for what is the most effective, and it's quite a range if you're looking at the severity of treatment that is presented. There's a big difference between the wait and see approach and surgical intervention. So the whole goal of this study is to attack this gap. That gap of knowledge led to my clinical question, and the reason I selected the two different therapeutic options are because they are low cost if you're looking at in terms of once you have the equipment, it's yours, it doesn't cost you a lot of maintenance to maintain. And also both of these treatment options fall under first aid or non-recordable treatments if you're looking at OSHA regulations. A recordable injury is an injury that requires formal documentation and further care down the healthcare line. So if you're looking at continuous ultrasound, it can be considered a thermal treatment because it is a heating treatment in the sense, and instrument-assisted soft tissue mobilization falls under the definition of massage. Both of these are considered under first aid as appropriate. Clinical plan, the population of the patients that would be involved range quite a bit in terms of age. They also range quite a bit in terms of what type of job they'll be doing, and then there's quite a bit of a gender difference at Dot Food specifically. There's more men than women, but we would have both genders involved in the process. The inclusion criteria: pain along the medial or lateral epicondyle, mechanism of injury is insidious in nature. The reason that I defined insidious because it's important to know that this is not an acute injury and it needs to be handled as a non-acute injury. And then evaluation and symptoms are consistent with medial or lateral epicondylitis. For exclusion criteria, we would exclude anyone that's had a fracture in the involved elbow, history of ulnar nerve transposition, patient is unable to attend a minimum of 2 treatment sessions weekly, and patient has a comorbidity in the involved arm. The reason I've specified a minimum of 2 treatment sessions is because we feel, at least at Dot Foods, that if we cannot work with a person more than 2 days a week, we're not going to see the benefit that would typically occur in the treatment process. And we're looking at a study that's trying to determine what is the most effective treatment, it makes sense to require a minimum of treatment sessions throughout the week. Other aspects of the clinical plan, that would be a 14 treatment session. All the patients would have to meet the criteria, and until there was a number of people that were no longer manageable by the staff, we would continue to accept patients without limitation. Outcomes variables would be administered at the end of each treatment week, and patients would be assigned treatment based off of location. The 2 location options are the frozen warehouse and the dry warehouse, and those are exactly as they sound. The frozen warehouse is typically at -5 degrees or colder, depending on the temperature outside. And then the dry warehouse is a non-controlled temperature, so it can be anywhere from 30 to 100 degrees, depending on the type of year. But they're 2 separate locations, so that would be the easiest way to randomize patients and what treatment they're assigned to. The basic research design would be a point-of-care clinical trial. This allows for an initial structured process. So if you're looking at in terms of screening patients and the informed consent process and how we separate those patients into their treatment groups. It allows for a more structured process like a randomized control trial. But it also gives us some flexibility throughout the study. So if some new data came in that would affect the process, the remaining process of the study, it would allow us to change that. The point of care clinical trial also allows for the clinical location to function normally, which is the whole goal behind this, is to see in the real world what is the most effective treatment option. Outcome variables that would be used would be the disabilities of the arm, shoulder, and hand, plus the work module, the SF-36, and the visual analog scale. Each of these gives a objective measure to pain, an objective measure to how this injury is affecting the patient, and an objective measure to how it's affecting them, not only physically, but in 8 different roles in terms of mental, physical, emotional, social roles. Stakeholders involved in this process would be, of course, the individual patient. Their buy-in is the biggest piece of it. They need to understand that the point of this study is to not only improve their situation, but to help their coworkers. And those coworkers could be family, they could be friends. So the impact that this study could have on those that they care about is huge. The occupational health team buy-in is also an important aspect of this piece, because even though there would only be 2 ATs involved in the process, having an entire team buy-in to be successful is a major part of it. The medical director would also be a stakeholder, just because we work under their license, and also because it took a long time to establish a good relationship with that medical director, and therefore we want to make sure they understand that what we're doing is to improve healthcare on site, as well as overall provide more consistency in the treatments that we offer. Warehouse managers would be the last stakeholders involved in the process, just because we would be taking employees off the floor for 10 to 20 minutes at a time, a couple times throughout the week, and it's important that they understand what kind of time we're spending with their people that are on a production standard. Feasibility. Overall, this would be a very feasible study for most locations. Overall, it's a low number of people that experience this injury, so it shouldn't be an overwhelming task to take on. Both treatment options that are presented take less than 10 minutes, depending on how quickly you get through each person. So time-wise, it's not a huge dedication. And in terms of length of study, it is a short study. It would only be 4 to probably 6 or 7 weeks, depending on how many times a week you can see someone based off of their schedule. Some challenges that specific locations could face would be how to randomize those patients. At Dot Foods, we have the option of 2 separate locations, but that would be a challenge for a high school setting that only has 1 athletic training facility. Another challenge would be staffing numbers. If you only have 1 athletic trainer on staff, that makes a big difference on how this study would be conducted. Required equipment would be the last possible challenge. Based off of what we currently have, that is not a challenge for our location, but if the location wanting to conduct the study did not have an ultrasound or did not have any instruments for soft tissue mobilization, it would be an initial expense for that location. Significance. If we're looking at the minimum clinically important differences, there are 3 that I've posted for the DASH, the SF-36, and the VAS. Each is backed by research. There's a little bit of variance if you're looking at all 3 separately, but each of those would prove if there is any clinical importance to what we're finding throughout the study. The biggest significance throughout the study would be for clinical practice would be providing consistency in treatment and injury management. Right now, with the treatment options that are presented, there's so much variance in what patients are receiving. So providing that consistency in treatment is a big first step, and would be a big step in our clinical practice as athletic trainers. Narrowing down conservative treatment options also goes along with that. There's not as much expense involved if we know exactly what treatment option to use on that specific type of patient. And the third significant impact on clinical practice would be reducing healthcare costs and improving recovery time. It's huge both in the occupational setting and the athletic setting for our patients to get back to whatever their physical activity is, and hopefully at a reduced cost. That's what we're there for. So helping them reduce what their expense is as a patient and improving their time back to physical activity would be a large impact. Thank you for listening to my presentation, and I look forward to your questions and feedback.